Okay, so hello everyone. We welcome you all to the second part of our head and neck slide seminar. So the slide seminar will be conducted as last time by Dr. Anita Borges, who is the lab director and consultant pathologist at Center for Oncopathology, supported by Tata Trust, Mumbai. Now, for those of you who are joining us new today, what we have done is we have chosen four residents to represent all of you and to simulate over the microscope learning experience. So we have Dr. Kshitija Kale, PGY3 at LTMMC Sion, Mumbai. Dr. Neha Mathew, PGY3 GGMC and JJ Hospital, Mumbai. Dr. Ashni Shah, PGY3 Tata Memorial Center, Mumbai. And Dr. Neelam Bhandari, who is a PGY3 at KEM and SGS Medical College, Mumbai. The session will be moderated by me. I'm Gaurav Chatterjee, Assistant Professor at the Department of Hematopathology, ACTREC, Tata Memorial Center, Mumbai. And the webinar is hosted, as always, by Dr. Sumit Gujral. So the structure of this webinar is Dr. Anita Borges will directly interact with Ashish, Neelam, Kshitija, and Neha. And as for you, the attendees, I will be working as a bridge between you and ma'am. So just feel free to use the chat section to ask anything that you like, and I will take those questions to Dr. Anita Borges. This is just the regular instructions. Please use the chat section to put your doubt. In case of any connection interruption, please click on the reconnect button. If still the issue doesn't resolve, send a private message to me, to the admin, that is. And for the polls, please answer in the options rather than typing in the chat section when the poll section comes up. These are a few of the disclaimers of our program. Because this is a slide seminar, just to highlight that the digitized slides are the proprietary property of the presenter, and any unauthorized reproduction of the same is strictly prohibited. So with that, we will start our today's session.
I think while while Gaurav is setting it up, and I'll go next. I think that the purpose of the slide seminar is really a learning experience. I think we use these two words, teaching and learning, as if the teacher teaches and the students learn. I think everybody has to understand that learning is not just a passive experience. Learning is very much an active experience, and to get the most out of this learning experience, I think an interaction between the teacher and the students is vital, and that's why we've introduced this new. I don't think it's new. We do it in a face-to-face way, but when we are on the web, we lose eye contact, and that can be a bit of a hindrance. Also, the next thing that I want to say is that if you are PGs out there, please try not to concentrate only on what is the diagnosis. The diagnosis is important, of course. That's what we are pathologists for. But there is a process that is involved in arriving at a diagnosis. And if that process is given a lot of attention to, and the approaches to this whole diagnostic process is paid attention to, I don't think that any we've got a cross connection somewhere.
Yeah, we have. Let me just.
Something about browsers. And again, there's an echo. Who's gone, Neelam?
Yes, Neelam will come back. It's better now, ma'am.
All right, good. So I think we did 4 cases the last time. We'll do 4 cases this time. And once again, try not to concentrate only on making a diagnosis. The diagnosis sometimes is very easy, but there is a lot that you can learn from the slides and in the process of making this diagnosis. All right. So let's go to who wants to take this case. I think Kshitija, would you like to start?
Yes, ma'am. We have a 73-year-old female with a biopsy done from a mass through an oroantral fistula.
Yeah,
Uh,
good. The last time we were just practicing, no, some time ago, and I asked you about an oroantral fistula. It's very important when we read a history to understand things about the history, not just what the patient experienced or what the signs were, but also from where the biopsy has come. So, would you like to tell us, Kshitija, what is this oroantral fistula?
Ma'am, oroantral fistula, it is a communication between the oral cavity and the maxillary sinus. And most commonly, it is after the extraction of molar tooth. So when the tooth is extracted, there is a passage which is formed from the alveolar ridge right to the maxillary sinus. And this
Yeah.
passage eventually gets epithelialized, and then we get this fistula, oroantral
Yes.
fistula.
So what I think Kshitija has learned is this oroantral fistula is not just some fistula that you get anywhere between the maxillary antrum, whether it's the palate or some other place. That it is actually almost always in either the premolar or the first molar tooth. And the reason that it happens over there is because the plate between the root of the tooth and the maxillary sinus is very thin in that particular uh, area, and so any kind of pathology in that area, whether it is a bad tooth or it is something that is in the maxillary antrum or anywhere else, that is the place where you get a break, and if that epithelializes, then you call it an oroantral fistula. All right, good. So let's go to the next thing. Yes, come on now.
Um,
Yeah, come on, Kshitija, you have to describe this.
Yes, ma'am. This is a biopsy bit from the mass which was there in the oroantral fistula. So, according to the five questions which we learned last time, so is the normal epithelium seen? So I think the normal epithelium is seen in these areas. Here and here, the normal epithelium is seen, and the rest of the tissue is abnormal. So we have stroma, and we have this particular area which is very much cellular, bluish looking cells, and admixed with no, epithelial stroma cells between them. So we have the normal looking and abnormal looking area.
I see. Okay. Everybody agrees with what Kshitija says? Ashish, as far as I could see, that I think I need the whiteboard. Yeah. Okay. Then she said that this area, I can't. I let me mark it. This area, Ashish, and
Yes.
I think you know that she said something here. Sorry. Let me mark that again. Yeah, this area, according to her, was normal. Ashish, you want to agree, disagree, or do you see normal areas, or what is it that you want to say?
Ma'am, I disagree. I don't feel that it is a normal epithelium over there.
Okay. So what? So do you see any normal tissue at all?
No, I don't see a normal tissue.
You don't see any normal tissue. What about Neelam? Neelam is not there. Neha,
Ma'am, I don't think there's anything normal in this.
anything normal. Now Kshitija, you heard, no, what they said, that they didn't think that there is anything normal. Why did you think that those two areas were that you marked? And I dare say you thought there were some other areas that were also normal. Why did you think that they were normal?
Uh, and I think the mass which is coming from the which is there in the oroantral fistula focally, it is lined by the squamous epithelium. So I
Okay.
think focally this part is the epithelium part, and so I thought
Now,
that is.
yes, okay. Neelam, I just want you to close your eyes. Not Neelam, Kshitija. Close your eyes and imagine that there is an oroantral fistula, and think, how do you think that this piece of tissue came through the oroantral fistula? What do you imagine is the clinical appearance of this tissue which came through through this fistula? Can you Can you articulate that?
Ma'am, maybe the most common lesion in the maxillary sinus
I
is
don't want to know about lesions. Here is a doctor. He's examining the patient, and he is seeing something in the region. It's obviously that one of the molar teeth has been extracted or fallen out, or something has happened, and now there is something that this dentist or this ENT surgeon is seeing. What is he seeing? Just describe what he's seeing. Like he was writing notes. You tell me, what notes would he write?
ma'am, some mass coming maybe from the maxillary sinus protruding down in the fistula, and that can be seen when the patient opens his mouth.
Right. So when you say mass, what do you mean, Kshitija?
Ma'am,
It is a huge thing. It is a. Now you can see what has been actually taken out, right? So what was it like?
maybe a fleshy mass.
Yes, so it's a fleshy mass that is protruding through this oroantral fistula, right? So now, do you think that you would automatically see there is a hole which is like a hole between, with a very thin bone in between. It's epithelialized and there is something fleshy popping out. Are you likely to see normal tissue? No. So that's something that should put your antennae up. I am seeing over here, and maybe if I can see this, look at this whole piece of tissue. Yeah, and this is what had popped out in through that hole. Is it very likely that it will be covered with some normal mucosa?
No.
Very unlikely, right? So we should be on our guard. Just assume that something that we are seeing, and the something that we're seeing, which made you think that this may be normal, is something that is squamous, right? And you expect that you see some squamous epithelium in the part, and therefore you feel, perhaps this is normal mucosa. But I think we have to agree with both Ashish and Neha that is unlikely that there is going to be much that is normal in this particular tissue. Yes? Neelam, do you agree that there's hardly anything likely to be normal over here?
Yes, ma'am, I agree.
You agree. Very good. Welcome to the show.
Thank you, ma'am.
All right. Now,
I'm sorry.
You say, Kshitija?
Yes, ma'am.
You were describing this, right?
Yes.
So now that we had this little side discussion, can you now look at this and just tell me what you're seeing at the scanning lens?
Oh, ma'am, we can see
predominantly you're marking, but when you're describing something, you're describing it to yourself. Okay, in your brain, you cannot mark something. And as I keep saying again and again, a good description is or a good descriptor, somebody who's making a description, should be so good that that person can be my eyes. If I go blind tomorrow, and if I'm so I have so much arrogance, and I think, oh, I've seen everything, and I want somebody just to be my eyes, and I'll be able to do pathology. So if you are going to be my eyes, please describe this such that I will get a mental picture of what you are seeing. That is the way of making a good description. So come on, now tell me at low power what you're seeing. And don't say that here I can see stroma and there I can, because I'm blind, I can't see. So now just draw for me a picture that you are seeing, which I should see in my mind. Okay, come on.
So we have a tissue bit which is predominantly composed of stroma and the neoplastic part. So stroma, so it is a loosely edematous stroma, and within the stroma there are sheets of neoplastic cells admixed with squamous, admixed with epithelial component.
Okay. Anybody wants to take a stab at that? Neha, you want to describe this? You have to describe it so that I can
I
actually see it. Yes, Neha, can you hear me?
It looks like a biopsy, which yes, ma'am, yes, ma'am.
Yes.
Biopsy showing lab
Can't hear you, Neha.
tumor cells.
I can't hear you. I've lost you. So maybe Neelam can try.
Ma'am, this is the biopsy from the mass, which is showing a tumor with cells that are arranged in sheets and nests, and few even trabeculae, and they are surrounded by stroma. And there are also few areas of hemorrhage. And these that's a ma'am.
Oh,
On
that's
this
it.
part.
Okay. Ashish, you want to take a stab at it?
Lesion is composed of a basaloid-looking cells arranged in a vague solid and glandular pattern with surrounding loose stroma.
Glandular. Okay. Now you have discovered glands in this thing. No, what I see is I can imagine that this thing is a piece of tissue that has been punched out, right, from this oroantral fistula, and you see that there is a surface to this thing. See, there is a surface at the bottom over here, right, and there is a raggedness at one end. So this thing has protruded, so there is a surface, and this seems to consist of just two types of elements. Yes, one which was described by Kshitija is largely a very blue. Can you see that? It's a very bluish gray stroma, and it's not very cellular. At this level, you can't see. So it is hypocellular but bluish gray stroma in which you can see the other element. And what is that other element? It's very basaloid. Yes, it looks like an epithelial structure that is basaloid and seems to have irregular spaces within it. Can you see that? Yeah,
Yes.
so there are these irregular spaces, and we don't call them glands until we know that it is a gland. Now, will anybody define for me what is a gland? What is a gland? Because, okay, Ashish, you use the word gland. Now tell me, what is a gland?
It is duct secreting. Hello.
Yes, I can hear you, Ashish. Now you've gone off. Yes, come on again. Yes, Ashish, you've got yourself muted. Can you hear me, Ashish? No, I can't hear you. All right, somebody else. What's a gland, Neha?
Ma'am, it's like a structure with a luminal structure which is lined by cells, and it has a secretory action also.
It has a secretory action. Okay. Neelam?
Yes, ma'am. A luminal structure lined by epithelial cells.
Lined by epithelial cells is a gland. You really think that that's a gland? You know, you have something in the lung, which is a space lined by flattened epithelium, which we call an alveolus. Yes? Is that a gland?
Yes. No, ma'am.
No, ma'am. So then what is a gland?
It has to have a function of secretion.
Secretion.
So it has to have secretions in it. Yes? And that means that cells of that particular structure, which has a central lumen, must have a secretory function. Yeah, that is essentially what is a gland. And we're talking about a histological gland. We're not talking about an anatomical gland, because there are many things that we call glands in an anatomical fashion, and that is thyroid gland and adrenal gland, and glands in the stomach and glands in the colon, and they are not all the same thing. So you have an anatomical gland like the salivary gland or the breast, which is also a modified sweat gland. We talk about all of these things, but we're talking about a histological structure that is a gland. So we cannot call these glands. We see that there are spaces, they are very irregular, and there's something else that you see, that there is an interconnection between what we think is an epithelial structure with each other, forming a lattice-like. Can you see that? There is a lattice-like structure that is being seen, which you're seeing. Oh, I'm sorry, you can't see my thing. Here is this lattice-like structure. There is another lattice-like structure that is seen. Oh, sorry, that is seen here. Yeah, so you can see this lattice-like structure, which is, or a reticulated structure, if you wish to call it that. And a reticulated structure is nothing but a net, like a net that is occurring. That is what is the meaning, or network. That is what reticulation is. So now you've got basaloid, you've got the stroma, which is very loose and looks grayish blue, and you have these epithelial cells. But you notice clearly here, and that I think was mentioned by Kshitija when she was first describing it, that there is, amidst all of this, there is one large area that looks more blue and more solid. Okay, so we seem to have areas that are less solid and areas that are more solid, which have this basaloid character. All right, so now let's go to the next thing. So now come on, Kshitija, you can continue. Will you tell me something about this?
Ma'am, we can see this picture represents a lining, a squamous epithelial lining, in which we can see the squamous epithelium, and the basal layer of that epithelium is showing hyperplasia, and at one point the cells are dysplastic and they seem to be invading down in the stroma.
All right. Now, you used the term dysplasia. You used the term dysplasia the last time as well, okay? Now, will you want to tell me what you mean by dysplasia?
Ma'am, dysplasia will be disorganized growth. So we will have two components. One will be the architecture distortion, and the second will be cellular atypia.
Okay. So now, you see some cellular atypia here?
Yes, ma'am.
You do. So what do you mean by cellular atypia?
Hyperchromasia, enlarged nucleus, high NC ratio.
Okay. Hyperchromasia. Yes? Hyper, then what? Hyper means more, right?
More.
Right. So more than what?
And the normal adjacent normal cells.
More than adjacent normal cells. So which are these adjacent normal cells? Can you show me? What are adjacent normal cells that have become more? Yeah, you've got your pointer, no?
Yes.
So show me the adjacent normal cells and tell me which has become more, because you're saying that there is hyperchromasia.
Ma'am, this part which I have drawn, this epithelium, it shows normal maturation. The cells are also aligned properly, but particular part, the cells are crowded and more blue-looking enlarged nuclei, and they seem to come down in the.
Okay, so now let me ask you. You keep on saying epithelium, and you say that this is, which epithelium are we talking about? What is this epithelium that you are saying is dysplastic? Which epithelium? Is it glandular epithelium? Is it respiratory epithelium? Is it squamous epithelium? What epithelium?
Squamous epithelium.
Squamous epithelium. So now this is a squamous epithelium, according to you. And in this squamous epithelium, you are seeing dysplasia. That's what you're saying, right? All right. We just said that this was, you yourself said basaloid. And so this is basaloid. And you are expecting that this is a dysplastic epithelium. That's why it's looking basaloid. Yeah. Anybody wants to disagree, Neelam? Agree, disagree, whatever.
Yeah. Ma'am, I disagree because I don't think this is the normal epithelium at all. So
Okay.
all the cells are part of the tumor.
So is there dysplasia? Then tell her. Is that dysplasia?
All these are tumor cells according to me. So I
So
don't
the
think
tumor
we
cells
can
are they dysplastic or not? Say I have a lipoma. All the cells in that tumor, are they looking like normal lipos? Are they dysplastic? I have an adenoma in the colon. Yes, it's a benign tumor, right?
Yeah.
Now, are those cells dysplastic?
So these cells need not be dysplastic, and
Uh-huh.
I don't think they are there. They look like basal cells, so they are basaloid. That's
They look like basal cells, and therefore. What about you, Neha? We are having a discussion here as to what is dysplasia. What do you think? That there is dysplasia? Okay, Ashish, tell me what is your idea of dysplasia?
First of all, ma'am, I don't consider this as a dysplastic epithelium
Okay, very
because
good.
this is a tumor. This is all the lesional cells that are there.
Mm-hmm.
And to compare for dysplasia, there should be some normal tissue as well to be sure.
So if there is no normal tissue, you cannot make a
No, ma'am.
diagnosis of dysplasia.
No, ma'am.
So
Both sides.
you all of you are stuck, no, as to how to define dysplasia. I don't know. Have you ever seen a colonic adenoma? You know, adenomatous polyp in the colon. Yes. Is that epithelium dysplastic or not dysplastic? It's an adenoma. It is. So what is that? What is the meaning of that dysplasia? And do we have to compare with something? No.
yes.
So, we have an issue over here. Okay, so we will come back to what is dysplasia later. But yes, three of you think, I don't know, Neha never opened her mouth, but at least two of you think that this is not dysplastic, and it is not dysplastic. Okay, so we will come to exactly what is dysplasia, because I think all of you have a very unformed idea of what is dysplasia. Okay, come on, Kshitija, continue to describe this. Yes, come, Kshitija. Never mind about the dysplasia. This is, how are you going to describe this structure? It's a very irregular island or of cells which have
Basaloid character.
Yes, it's a basaloid character, and it seems to have small
Palisading at the.
yes, there is a palisading at the periphery. Very good. You can see that. Yeah. And what is this palisade? Why did you say it was palisading?
Because the cells at the edge are parallel to each other and perpendicular to the surface.
So there is a surface, and this is the basement membrane. Yes. And then these cells are all columnar, and they're parallel to each other, but they're perpendicular to the surface. So you can use that word palisade for many things, including palisades in spindle cell tumors, yeah, where you have a bundle that is running, and all of the nuclei are parallel to one another, but perpendicular to the direction in which that bundle is running. Very good. And also you have these little cords of cells that seem to protrude from the basement membrane. Yes or no?
Ma'am, we can't see your pointer, ma'am. Can you turn the white?
Yes. Oh, I'm so sorry. Yeah. So now you can see that you have these little. Oh, this doesn't. See these little cords of cells? No, it's still not come. Why doesn't it work? It doesn't seem to work for me today. The whiteboard won't turn white. Okay, you see these little. It's gone off. I don't know if you can do something about it.
It's on now, ma'am. It's whiteboard is on now. You can just draw.
It's not. In fact, it's not. It's gone.
Ma'am, it's not transparent. It's basically it's transparent. You can draw anything on it now, ma'am.
No, I don't think it. Oh, it can. Oh, all right. Here you are. These are these little cords of cells that are also the same, attached to the to this epithelial island that are protruding from it. You can see that, right? Okay.
Yes, ma'am.
And if you remember that they loop here, they are looping back on themselves, and also where you saw that lattice-like framework, that is exactly what these cords are doing. All right, let's go to the next thing. Let's see if we can look at it at higher power. Now, what do you think? Do you think there's dysplasia?
No, ma'am.
No.
The architectural arrangement is properly aligned.
Architecture is? See, all of you are, or at least some of you are assuming that this is squamous epithelium. Suppose it is not squamous epithelium, huh? And you have got this basaloid palisading at the periphery, and you notice something which Dr. Asavari showed you so beautifully that day. Yeah, on your normal basal cells, where do the nuclei lie?
Basally.
They are at the basement membrane. Where are these nuclei now? Away from the basement membrane. So, what kind of epithelium do you think you're looking at then? You think this is squamous epithelium? No, it has got squamous. It has got squamous islands over here. You can see a squamous island here. You can see a large area where this basaloid epithelium, they are all epithelial cells, is actually maturing towards squamous epithelium. You can even see granules. You can see keratohyalin granules over there. But this is not the basal type epithelium that you see in squamous epithelium. So what do you think it could possibly be?
Ameloblastic epithelium.
Oh, so now we have amyloblastic epithelium. Huh? Look at this. And you can actually see keratohyalin granules even in this group of cells. And here you see spaces lined by those same basal cells. Yeah? And look at the stroma. The stroma is loose, it is myxoid, and it is vascularized. So what you have here is an epithelium. It is an epithelium, but what kind of epithelium? Just because it has keratinizing squamous epithelium, that doesn't make it squamous epithelium. Okay? So now we know. See this at higher power now?
Yes.
What do you see? You see that basal palisading? Now you see the basal palisading. Oops. You see the basal palisading over here, and what do you notice about it?
Reverse polarity.
That you can see that the nuclei are away from the basement membrane. So, where does the question of dysplasia and all of this come in? We are not looking at squamous epithelium. We are looking at another epithelium which is showing squamous differentiation, and that epithelium is amyloblastic epithelium. So now we know what we are dealing with. What are we dealing with? We're dealing with, if there's amyloblastic epithelium, it has to be an ameloblastoma. Yeah, but something else has happened in this ameloblastoma. And now we come to this area where Kshitija was talking about. Yes? Look at this whole area over here. What is it? Now you have to describe this, Kshitija. We've come to high power. What is it?
This is a hypercellular area showing cells with advanced nucleus, moderate eosinophilic cytoplasm, and prominent nucleoli. From that, typical mitotic figures and nuclear pleomorphism.
Right. Can you see any mitotic figures?
Yes, ma'am. Two mitotic figures.
Two mitotic figures. You think this is one mitotic figure here Oops, this thing doesn't behave itself. Oh, God. I have problems. Yes, here is a mitotic figure, right?
Yes, ma'am.
Yeah, and you've marked a mitotic figure. Yes, very good. How do you know that they are mitoses?
And the nuclear material is seen going away, going towards the poles. So that means that the cell is getting divided.
It has divided.
It
The
is
cells have divided.
it is in the process of division. Only the nuclear material is driven towards the poles.
Ah, okay. But where is the nuclear membrane? Kshitija? Mitosis takes place inside the nucleus, no? Kshitija?
Yes, ma'am.
Yeah, so where is the nuclear membrane in all of these things that you have drawn, that I have drawn and you have drawn? Where is the nuclear membrane?
It's not.
It's not there. Okay. Neha, where is the nuclear membrane gone?
Like it's involved in the process of mitosis.
It's involved in the process of mitosis. What does that mean? Neelam?
Like the chromatin material.
Yes, I know that. Mitosis takes place within the nucleus. Yes or no? Yes, Neha, or no? Come on. It has to be yes,
Yes,
or
ma'am.
no. Yes. Neelam.
Ma'am, in mitosis, the entire cell will divide. So,
Oh, yeah, the entire cell will divide. It has not yet reached the stage where it is going to divide. So where does mitosis take place? Inside the nucleus or not inside the nucleus? Ashish?
Inside.
Inside the nucleus. So where is the nuclear membrane gone? Anybody? Anybody in the chat box is saying where the nuclear the nuclear membrane has gone? You know that in mitosis, the first thing that happens is that the nuclear membrane disappears. All right, and then you have what is happening inside there is in the for all practical purposes, it is happening in the cytoplasm. And if you ever see something that looks like a mitosis, but there is a nuclear membrane around it, it is not a mitosis. It's an artifact or it is something else. Please understand that. So that you have to look for mitotic figures starting from prophase all the way to telophase
telophase.
within the cytoplasm. It is not inside. Yes, the contents of the nucleus, which is the DNA, is actually undergoing, if the chromosomes are undergoing these divisions, because mitosis is not the same thing as DNA replication. Do you understand that? So while DNA replication in the S phase is occurring, it is occurring within the nucleus. Yes, the moment mitosis starts, the nuclear membrane goes, the chromosomes then start to align themselves in, because the DNA is already replicated. It's replicated during S phase, and every cell that enters S phase does not necessarily enter into mitosis. Do you realize that? There is another phase that comes after S phase. And what is that?
M phase.
What comes? What can you tell me the cell cycle? From G0 it goes into,
G1.
and then
G0,
S.
G1, S,
it gets into
G2,
G1, then
S,
S, then
G2.
G2,
and it's after G2 that it goes into
M phase.
M phase.
Exactly. So the nuclear membrane has to go. So yes, there are a lot of mitosis. So I'm getting an echo again, which means somebody's mic is on. All right. So you see these big cells. They are epithelial cells, and you've described them. They're huge. They've got nucleoli, very vesicular nuclei with the nucleoli, and of course there are lots of mitoses. Okay, so now come on, you guys. What's the diagnosis? Yes, Kshitija, because you started.
And it will be ameloblastoma because we saw the ameloblastic epithelium.
Yes, very good.
Ma'am, but the cells in the last slide which we saw, they had prominent eosinophilic nucleoli. So can we think of melanoma?
Can we think melanoma? All right. So, anybody to say anything to Kshitija? We've just got the salient features, over here. Yes. And what do you see? Interconnected islands of basaloid epithelial cells, basal palisading with nuclei away from the basement membrane. There are keratinizing foci. And what is this pattern? Now we know it is an ameloblastoma. And what do you expect to see in an ameloblastoma?
Islands.
You ever heard the word stellate reticulum?
Yes.
So now you see the stellate reticulum, which maybe you didn't even recognize. All right, there is this interconnected, cells over there, which look almost as if it's a jigsaw puzzle that has been shaken loose. So that's the stellate reticulum that is being seen in these cells. And then, of course, Kshitija said that there was something else. And what was that something else? You saw single focus of a confluent sheet of cells with little cytoplasm, large vesicular nuclei, coarse chromatin, and mitoses. So now Kshitija says maybe this is a melanoma. So do you think, Kshitija, that this is a melanoma within an ameloblastoma? Does it sound very likely that this is what's going to happen? No. So now, Neha?
Ma'am, ameloblastic carcinoma.
Ameloblastic carcinoma. Excellent. Neelam, do you agree?
Yes, ma'am.
Do you agree? You don't have to agree just because she said so.
No, I agree. That was what I thought.
Okay. And Ashish?
Yes, ma'am, because of the cytological atypia.
So now how did this happen? You have got a very benign looking ameloblastoma, and you have a very high grade. What is the word that you will use? Transformation. So is this a basaloid squamous carcinoma? The answer is no. Is it an ameloblastoma with malignant transformation? The answer is yes. It's very unlikely to be an odd type of salivary gland carcinoma, right? So the answer is ameloblastoma with malignant transformation. Did anybody answer a poll? I don't know whether Gaurav
Yes.
the poll.
Yes, ma'am. So 96% people answered that ameloblastoma with malignant
transformation. So that's absolutely good. So well done. Now let's go on to our. This is just to show you we did some immunohistochemistry just for the fun of it, and you can see that this is cytokeratin, and you should realize that all ameloblastomas will express cytokeratin. There's very little being expressed in the malignant area, which is, you can see the little dot-like transformation over there. Here you can see P63. All ameloblastomas will also express P63, but you see almost complete absence of P63, and I've shown you a high power of that area in the malignant part. You can see here, this is MIB1, and anybody can see that the MIB1, which tells you about the rate of proliferation, is very high in that malignant part and low, because you can see you can see how dense is the number of dots that you will see, because the nuclei will have picked up the brown stain for the MIB1. But just to our surprise, that malignant transformation part showed synaptophysin and also showed chromogranin. Anybody wants to change their diagnoses now? Anybody? Ashish, you want to change your diagnosis? What about you? No. What about you, Kshitija? No. So why do we have synaptophysin and chromogranin? What does synaptophysin and chromogranin mean?
Neuroendocrine differentiation.
Neuroendocrine differentiation. So why are we seeing this here?
It can show.
Yeah, so anything that becomes very highly malignant, or the transformation shows a high grade transformation, may show you some neuroendocrine markers. You see it in high grade prostate cancers, you see it sometimes in high grade adenocarcinomas, whether of the lung or the GI tract or whatever. It's an adenocarcinoma, but it just, when you do find neuroendocrine differentiation on immunohistochemistry, this does not look in any way like a neuroendocrine tumor. It doesn't look like that at all. You may see neuroendocrine differentiation. All right, so now let's go to our next case, which is very easy. Who wants to take this now, Neha?
Yes, ma'am.
Read it.
We have a biopsy from a bone from a patient who had pain and swelling in the lower jaw.
Okay. Come on, describe it now. This is easy.
So we have a tumor arranged in diffuse sheets with multiple cystic spaces, which is seen invading into the bone.
Okay. So you see normal tissue, that's the bone, right?
Yes,
and you see a tumor that is in sheets. And
now it looks like sheets with some spaces filled with some secretions.
All right.
Ma'am, before we go to this case, like I can just tell you, there is one question
okay, good. Yeah, I'll answer it, please.
So the question was that which type of ameloblastoma can we say which has undergone transformation, like basal, follicular, acanthomatous, etc. So somebody has asked.
This is a question that has come from a dental oral pathologist. I'm absolutely certain, and it doesn't make any difference to me. All ameloblastomas have got the same propensity to undergo malignant transformation, and it doesn't matter to me whether this is a acanthomatous or it is a follicular or it is any type of ameloblastoma. It's the same. Okay, and certainly from this biopsy, I'm not going to make a diagnosis of the type of ameloblastoma. Okay, the dental people are obsessed with types of ameloblastoma because obviously that's an odontogenic tumor that they see a lot about. Yes, come on now. So we go to the next one.
Here, ma'am, these cell tumors are
yes,
like pattern or a tubular pattern, and then they are infiltrating into the bony tissue, and there are areas of hemorrhage as well.
All right. So what pattern did you say that you saw in this?
Tubular or a duct-like pattern.
Tubular or a duct-like pattern. Everybody agrees that this is a tubular or a duct-like pattern?
Follicular pattern.
Who said that?
Kshitija.
Yes, okay. What do you think, Neelam?
We could call it glandular also.
Glandular pattern, okay. But Ashish? Ashish, what pattern?
Glandular.
Glandular. All right. So Ashish thinks it's glandular. Somebody else thinks it's glandular. That's Neelam. Somebody thinks it's tubular. And I think, who said that it was follicular? Kshitija. Okay. So now we have to figure out whether this tumor is growing as glands, acini, ducts, tubules, follicles, or alveoli. Look at that. 1, 2, 3, 4, 5, 6. 6 different options you have. And I think the audience can also do a poll if they wish to. And we have to answer the question, how do we distinguish glands from acini, from ducts, from tubules, from follicles and alveoli? Now, who wants to take glands? We already did a little bit about glands before, so maybe we can skip that, because we said that this is a structure that must have a lumen and it has to be lined by epithelial cells, and those epithelial cells must make a secretion. Okay, and that secretion can actually must get into that gland. Either the whole cell falls into the gland, or part of the cell falls into the gland, or the secretion goes into the gland, right? So that's why we have exocrine glands, we have
Holocrine.
holocrine, and we have apocrine, right? Yes. So
Just to
now,
update on the poll result, so
yes,
43% of people think it's follicles, and
yes.
20% think it's glands. So rest of them have like around 10% people think it's acini, ducts, and tubule.
So it is glands and follicles, right?
Yes.
Oh, okay, very good. So now, so the glands wallas are getting quite excited. Neelam and and Ashish, very good. You've got 40% of these people agreeing with you. Only 20% of them are agreeing with Kshitija. What did you think, Neha? I'm sorry, you thought ducts.
Ma'am, in this focus, I was thinking of follicles, but in the second slide, I think it was tubules.
You thought it was tubules. Okay, right. So now we've discussed what is a gland. So then what is an acinus?
Acinus is kind of like a grape-like cluster, and they could be a lumen or it could not be visible.
Acinus is a grape-like structure. Acinus is, who said that? Neha. Neha, yes. Acinus is a grape-like structure. Do you know any organ that has an acinus? Tell me an organ or a that has an acinus. Neha, do you know anything that has an acinus?
Pancreas, ma'am.
Pancreas, very good. Pancreatic glands. Pancreas has got acini. Excellent. So, tell me, what is an acinus if you know it? You mean the pancreas has got grape-like structures with or without a lumen? What is the function of the acinus in the pancreas, or for that matter in the salivary gland? What is the function?
Secretion.
Secretion. So it may or may not have a lumen. I find that very interesting, because if there is a secretion...
No, ma'am, it's smaller than...
Sorry?
It has to have a lumen.
It has to have a lumen. Oh,
it has to have a lumen.
Okay. So it's also a secretory structure, isn't it? Yes or no? So then how does it differ from a gland? Because a gland, and it has to have a lumen. You agree? Yes. So now you tell me, what's the difference between an acinus and a gland? They're both secretory.
There's a difference in the size.
Very good. Number one is the difference in the size. And
lining epithelium, glands are lined by columnar cells, acini are lined by triangular cells.
Triangular cells. Well, that's because it's small. Yes. Huh? You may get some acini that are aligned by things that are low cuboidal. So they doesn't have to be triangular. Yes. But the lumen is small. It is the terminal portion of a whole secretory ductal apparatus. Okay, you cannot get an acinus, for instance, in the colon. You get glands in the colon, but the colon has no ducts. Do you understand that? There are no ducts. So if you have something that has a secretory apparatus that has both a secreting portion and a ductular portion, so which takes the secretion and dumps it somewhere else, then that terminal portion where the secretion is actually being made is an acinus. Okay, so you've got all kinds of glands, but an acinus is essentially the terminal portion of a secretory ductular apparatus. Okay, so you can't get an acinus in the colon. It doesn't occur. Are you getting that the concept now? Okay. Yes. All right. So first of all, it has to be small. Now here, there are some very small structures, and how do we know that this is not a gland? But this is not an acinus. But you are not likely to get so many crowded and such large acini even if it is growing in a tumor. So the size is wrong in this case for an acinus. Okay. Now, What about ducts?
Ducts don't have secretory function.
So it's an elongated structure. Yes, usually cylindrical. So when you cut a duct, actually tangentially, you're not going to see any cells that are secretory. Occasionally, you might find there are some mucinous cells somewhere that may be in a duct. But by and large, there is nothing that is that these ducts are actually secreting as such. Okay, so it is just a transport structure. And what is a tubule? It's just a small duct, because it's a
Duct.
so you have ducts, ductules, tubules are more or less the same sort of thing. So they're small little structures which do not have any secretions in them. Now, what is a follicle? Anybody wants to define a follicle? Come on, what's a follicle? Where do you see follicles?
Thyroid.
Thyroid. Any other place? Any other place you see follicles? There are 4 women on the screen over here.
Ovarian.
Ovary.
Okay. So the ovaries. Okay. Any other place you see follicles? No? You have a large organ on in the upper left-hand side corner of your abdomen. What is that? That's a spleen, right? So,
Lymphoid follicles.
right, and the lymph node. So the spleen, the lymph node, ovarian. We're talking about the thyroid. So what's in common between all of these things that we call them follicles? Why do you have a lymphoid follicle, you have an ovarian follicle, you have a splenic follicle, and you have a thyroid follicle? What's in common? It can't be the lumen.
It's an assembly of cells which different types of cells, but they perform.
Sorry, I lost you, Kshitija.
And it's an assembly of cells which will perform a particular function. So
I don't think so.
The shape,
Yes. What is the shape, Neha?
like round.
It's spherical. It's a spherical structure. That is all that a follicle means. You have hair follicles. All right. The hair follicle is a spherical structure, right? And from that you have the hair shaft, and but the hair follicle itself is a spherical structure. So that's what a follicle is. It's a spherical structure. It may or may not have a lumen. All right, the one in the thyroid and the one in the ovary has a lumen, but they are all spherical wherever they occur. So that's why we call them follicles. Okay, now you can see that these are all one shape. Can you see that? Yeah, now that tells you something. If this was a gland, all right, glands are not spherical. Glands are all kinds of different shapes. So if you are cutting a spherical structure, you are very likely to get all rounded. Yes, and that makes you exactly. That's why the thyroid follicle, when you look at it, is not all different shapes. They're all circular when you cut them in whatever plane that you cut them, because it's a lot of balls that are all together, yes, which are being cut. When you cut them, whatever the plane you're cutting it, you are going to get a circular lumen. If it is yeah, that's why all these, they're all circular when you cut them, because it's a spherical shape. Ducts, glands, etc. Depending on how you cut them, you will either get a spherical shape or you will get a tangential cut in which the lumen may be elongated. You'll never get that in a follicle. Yeah, see, it stands to reason. Once you know it is spherical, then there is no question about that. Now, we come to the last thing. What's an alveolus? What's an alveolus and where do you find them?
It's a surface and cells are clinging along the surface from all the sides towards the inside.
Where do you normally see alveoli?
Lung.
Lung. Anywhere else? Yes.
And
This
it's
is this is an oral thing, no? Head and neck. You know any place?
Yes, ma'am. The alveolar process of the mandible and
Why is it
maxilla.
called the alveolar process of the mandible and the alveolar process of the maxilla?
It is that it has that shape of like a
What shape?
sack. I mean,
Yeah, it's a sack-like shape.
Yeah.
All right. So that's what an alveolus is. It is a sac-like structure and it is large. It is not like an acinus. It's a large sac-like structure. You can't have a tiny lumen in an alveolus. You understood that? So it's circumscribed, it is sac-like, and yes, it has some cells that are lining or must have some cells that are lining that lumen, but they don't have to be epithelial. Have you understood that? You in your alveolar in the alveolus and the mandible, there is no epithelium. Okay, it's not lined by epithelium, it's lined by bone. Yeah. In the alveolus and the lung, there is an epithelium. But you don't always have to get an epithelium. You can still get a lumen and you can get a blind sac-like structure, and it can be anything that is lining that structure. So now, having said this, please tell me, what would you pick? Gland, acinus, or let me say, what won't you pick? First, let us say what you will not pick. Come on, Ashish. What will you not pick out of all of this? Tell me.
Ducts and alveoli.
Ducts,
And
alveoli.
acini.
Okay, so you will not pick acina, you will not pick ducts, you will not pick tubules, because tubules are small things, right?
Okay.
Yeah. And alveoli. Very good. So you're left with
gland
and
and
then
follicles.
follicles. All right, good. What about you, Kshitija? What will you not pick?
Ma'am, follicles are more likely because they are all spherical.
Okay. So you insist that it's follicles, and that's good. What about you, Neelam?
They are all round, but
They're all round. There's nothing that is not round. They're all circular.
so probably I'll pick follicles.
Very good. What about you, Neha?
Ma'am, I'll go with follicles.
We'll go with follicles. Excellent. So this is yes. Oh, I have to go next. Some might want to say that these are acini, but they're too large to be acini. Cannot be glands, ducts, tubules, or alveoli. These, in my book, this is a follicle. Okay, because for acini, it has to be with a really small lumen, and these lumina are too large. Very good. So what's your diagnosis now? If this is, what would you say? We know that it is an epithelial tumor in bone. Yes or no? Yes. It's a tumor composed of sheets of cells arranged in follicles containing a dense pink secretion. Now, what are your options? What are your options? Well, whenever you look at anything, you decide whether something is benign or malignant. If you think it's malignant, you'll have to say, is it primary or metastatic? And then what is its subtype? So do you think that these are the possible diagnoses?
Yes, ma'am.
Salivary
ma'am.
gland tumor in bone, so what is that? It could be an acinosal carcinoma. What kind of salivary gland tumor? What kind of salivary gland tumor? Don't say yes, ma'am. Tell me. In the meantime, Gaurav is going to give us our poll.
Yeah, so it was again real type, ma'am. Almost 1/3 of people have opted for each of these diagnoses.
Oh, really?
Yeah, the highest percentage is actually to follicular ameloblastoma, which 38% of people think it's a follicular ameloblastoma, followed by the metastatic carcinoma, which 33% of people think.
Okay. And followed by some salivary gland tumor in bone.
Yes,
So
that also around 27%. So it's almost
23%. Well, I just as a lark, I put in salivary gland tumor and follicular amyloblastoma because people think that follicles that are follicular amyloblastoma is actually forming epithelial-like follicles. No, they don't. And anybody who wants to go and see what a follicular amyloblastoma looks like, just go and look at the pictures. I don't have a picture to show you, but this is not a follicular amyloblastoma. It does not have the look of an amyloblastoma. Amyloblastoma we just saw in the previous slide. It's a basaloid tumor. This is not a basaloid tumor. Can never be a follicular amyloblastoma. Salivary gland tumor, yeah. If you think that all these round structures can occur and that they occur in, say, an actinic cell carcinoma, but you think an actinic cell carcinoma primarily will occur in the bone?
Oh, ma'am.
The answer is no. So this must be very low on your list. So what is the diagnosis? It's probably a metastatic carcinoma. With a follicular appearance. Now, which is that metastatic carcinoma with a follicular appearance? Only one, no?
Thyroid.
Thyroid.
Metastatic follicular carcinoma of the thyroid in bone. It's not a difficult diagnosis. It just requires not to call them glands. That's number one. Otherwise, you wouldn't reach the diagnosis of follicular carcinoma in bone. Okay. And just in case there are disbelievers, I will show you thyroglobulin and TTM. We don't need to do that, for God's sake. This is metastatic follicular carcinoma in bone. All right, good. Who's the next person now who's going to come up? I think Gaurav will have to load the next lot of slides. If there are any questions that you have, or if anything has come on the chat box, I'll be happy to take them in the meantime. Any questions? Neelam, did you get the diagnosis of metastatic follicular carcinoma?
Yes, ma'am. Yes.
Oh, you did. Neha?
Yes, ma'am.
Yes. What about you, Kshitija?
Yes, ma'am.
Yes. All right. Very good. And Ashish, you too. Very good. Excellent. But you call them glands. So how you made a diagnosis of metastatic follicular carcinoma in bone when you thought they were glands is a mystery to me. But anyway, come on, Neelam. You want to take this?
Yes, ma'am. History says adult female, recurrent lesion on the lip after 8 years, previous histology unknown.
That's the usual story in our part of the world, right? We don't know what the history was. Okay, come on now.
Ma'am, this image shows a lesion with multiple cystic spaces along with large areas of hemorrhage reaching up to the mucosal lining. And the tumor cells seem to be arranged in a, at this part, not very sure, ma'am, but a vague glandular pattern. Surrounded by these lakes of, homogeneous looking acellular eosinophilic material.
Okay. Which mucosa is this?
Ma'am, the squamous mucosa. The stratified squamous.
Mucosa of the lip. Are you sure it's mucosa?
Ma'am, actually, on the right side, I can see keratin. Should I mark it? Ma'am, this portion.
This portion is what?
Is keratinized.
Is keratinized. Why do you think it's keratinized?
Ma'am, I feel that dense pink material on top looks like keratin.
Looks like keratin. She thinks that it is keratin. Anybody else who thinks that it's keratin? Ashish? You think it's keratin?
I think, ma'am, the mucosa is thinned out.
The mucosa is thinned out. Yes, Neha?
Ma'am, I think it's keratin only.
You think it's keratin. What about Kshitija?
Ma'am, I think it is taken from the Vermilion border. So on the left-hand side, we can see the keratinized squamous mucosa with the tongue going. And the one which she has marked, it's the normal mucosal lining.
I see. So, a normal mucosal lining, according to you, Kshitija, is what kind of mucosa on the inside of the lip? Because you, according to you, this thing, yes, oops, is, I can never do this thing. This thing is skin, right? According to you,
Yes,
this is
ma'am.
skin, right? All of this,
Yes.
yes, Kshitija? And
Yes,
according to
ma'am.
you, this is the mucosa. First of all, I want to know what is skin. Will anybody dare please tell me what is skin? I know it sounds like I'm asking a stupid question, but I want to know, particularly because Kshitija thinks that this is skin. What is skin?
Ma'am, skin is made of epidermis and dermis, and the
Right.
epidermis is keratinized stratified
Hey.
squamous epithelium.
So now, according to Kshitija, this is skin. Yeah. Why? Because there is squamous epithelium, it becomes skin? I don't think so. Why should it be skin? All right, very good. So this may be skin, it may be, what is the lining of the inside of the lip? What kind of
Non-keratinized.
epithelium? What is it?
Non-keratinized.
Non-keratinized squamous
Keratinized.
epithelium. All right, good. So it could as well be on the inside of the lip. Now, if this is keratin, what do you think this is? And what keratin forms as the outermost layer? How many layers should there be below it, deep to it?
4 layers at least.
4 layers at least.
I mean, no, keratin is formed from the corneal layer, so 3 more layers below.
3 more layers below. So there is one basal layer, there is one layer of spinous process, and then there is. You mean those are the layers, but how many actual layers of cells? Is
At
it
least
6
10,
layers, 8 layers, 10 layers? What?
ma'am, at least 10 to 15.
Oh, 10 to 15. No, it doesn't reach 10 to 15, but it
Two.
can't be less than, sort of 5. And do you think that there are so many cells below this?
No, ma'am.
So everybody who thought that this is keratin must be, you need your eyes to be a little. This could very well be part of this tumor, okay, which is just some columnar epithelium over here. It could very well be that you can see a palisade actually all the way through. So please, this is not keratin. Have you understood that? It cannot be keratin. There is no way that it is, because you would have had to have so many layers or stratified layers below that. So this is not keratin. Okay, very good. So now, you said you didn't know whether to call these things glands. Yeah?
At this part,
What would you want to call it? At this part or any part? What would you call this? Because you have to describe this. I'm blind, and I need to know, to get a visual, sort of in my mind.
ma'am, there are these multiple cysts, the ones with the single
Then why don't we
lining.
leave it as cysts? These are cysts lined by a single layer. Can you see that?
Yes,
It's
ma'am.
a single, yeah. So why don't we say that these are cysts? Okay, there's hemorrhage within the cyst. You can see this, and there is some proliferation of the lining epithelium of the cyst. At least in the larger cyst, you can see that, but the others are all single-lined epithelial cysts. What's the big issue? And do you think that this cystic structure and its epithelium is actually coming or is arising in the overlying epithelium? Is it? Do you think that this is, when we say what is the relationship of the lesion to the normal? So what is the relationship? Is it arising from, or is it deep to?
Deep too.
So it is deep too. So that's something that you can say, that this does not appear to be arising from the overlying epithelium. All right, and there is some sort of inflammatory thing over there.
Yes,
Something.
ma'am.
All right, good. Now let's go to look at this at higher power. What do you see? Now you can see the cells better, no?
Hello.
Yes, can you hear me?
Yes, ma'am.
So tell me about the cells now in this particular thing. This is a higher power.
The slide hasn't changed for me.
It hasn't changed for you?
No, ma'am.
Uh, it's changed for me. Has it changed for everybody else?
Yes, ma'am.
Yeah. Can you see it now, Neha? Not changed for
Yes,
you?
ma'am.
No, it hasn't changed for. Sorry, it has not changed for Neelam. All right, one of you others for whom it has changed, can you please? Maybe there's a lag. Has it changed now? For Neelam, it hasn't changed. All right, come on, Neha. Can you please describe this? What are the cells look
Ma'am, there is a ma'am cells. The lower portion it looks very solid, and then there's like a vague glandular pattern of the structures arising from it.
Okay, it has changed now.
It has changed. Okay. All
Yes.
right. So you've got a lag. So now tell me what the cells look like.
Ma'am, these cells they look like cuboidal. They look uniform, cuboidal to low columnar, and
Okay.
the nuclei are round.
You finished with the cytoplasm.
No, ma'am.
We
And the
jump immediately to the nucleus. Why?
okay. And the cytoplasm is eosinophilic, but some of the cytoplasm shows vacuolations, I feel.
So you have got both. There, you're right. They're cuboidal or low columnar, and they have vacuolated or eosinophilic cytoplasm. Very good. And you've got this colloid-like material. It may be serum. I don't know. That is present within these cysts, and a lot of hemorrhage. All right, here it is at even higher power. Now, come on.
Yes, ma'am. Again, these cells, they have nuclei which they are cuboidal in shape, and the vacuoles are even more prominent at the cytoplasmic vacuoles.
Yes, so it's multi-vacuolated. It's not univacuolated. No, so there are
Okay, multiple vacuoles.
multiple vacuoles in the site. What about the nucleus?
The nuclei look round to oval and with condensed chromatin.
Do you think that this is condensed chromatin?
I think in some
This
places, ma'am,
is
it has.
condensed chromatin.
In some places, it looks pale vesicular, I feel.
All right, so they're pale nuclei, but you really can't see much of the
Ma'am,
nucleus structure here, right? All
I think
right,
it's covered in secretion.
covered in secretions. What about this now? This is another part of that tumor.
Yes, ma'am. Here the cells, their cell borders are not distinct, and the cytoplasm looks pale eosinophilic, and also some places vacuolated, multivacuolated, and the nuclei look round to oval, vesicular, pale, with one or two prominent nucleoli in many of them.
All right.
And also there are these lakes of this eosinophilic acellular material in between these cells.
All right. But do you think the cells are arranged in any kind of formation?
Mm.
Are they just sheets, or are they? Can you see any formations over here?
Vague cystic pattern only, I feel.
Vague cystic pattern. Do you think these colloidal-like structures are present in what? Inside a lumen or in the stroma? Inside the lumen or in the stroma?
Inside a lumen.
Inside the lumen. Can you see lumina or not? You see small and large, but most of the lumina that you see, and there are many lumina, are small lumina. So small that you can't actually see them in many instances, except where those these colloid-like, what you call a lake, but a colloid-like structures are present inside the lumina. Okay, let's go to even higher power. What do you see now?
Yes, ma'am. Again, here the cells, their cell borders don't look distinct at all. Then the cytoplasm is pale eosinophilic, and it is moderate to, I feel, abundant also in some cells. Then there are these multiple vacuoles in the cytoplasm.
Excellent.
Then the nuclei look round to oval. Some of them are even showing mild pleomorphism, different sizes. And
Different sizes is not pleomorphism. Different
map
sizes is,
shapes and sizes, yeah.
huh? What is different sizes called?
Anisocytosis.
That's cytosis. If it's the nucleus, then
Anisonucleosis.
Anisonucleosis.
isonucleosis. All right. Okay, and you can see the number of small lumina. They're
Yes,
all
ma'am.
there. Ah, okay. You saw large lumina in the thing that you wanted to call follicles. Yeah. Are all these lumina of the same circular shape?
No, ma'am. They have different some are circular, some are irregular
So
shape.
this I don't think you will want to call these follicles, would you?
No, ma'am.
No, you wouldn't want to call them follicles. All right. Very good. Here, what do you see?
Then here, ma'am, I feel the cells are taking a sort of either sheet-like appearance,
Hmm.
or some look like in cords also.
All right.
And again, the cytoplasm is eosinophilic, moderate to abundant in quantity. There are these small uh, lumina present. Some of
Yeah.
them must be the vacuoles in the cytoplasm.
Yeah. Actually, the cytoplasm both here and in the previous, they're not very pink, they're more amphiphilic, right? So
Pale
it's
amphiphilic.
varying from pink to eosinophilic to amphiphilic. All right. So now come on. What did you think it was?
Ma'am, the first differential was I thought of a secretory carcinoma.
All right. That's good. Why are you being diffident about it? All right. Anybody else has got any, or you have another differential diagnosis?
Acinic cell carcinoma would be, but I don't feel that the cells have those zymogen granules that usually we
Okay.
are supposed
All
to
right.
find.
Very good. Anybody else? Ashish?
Ma'am, I would also like to go with the same differentials.
What? Secretory carcinoma and acinic cell carcinoma. All right.
Yes, ma'am.
Neha?
Yes, ma'am, same.
Same. And what about Chitija? Same. How did you come to that diagnosis? Just by matching pictures?
Ma'am, I was reading the salivary gland tumors, and then
Ah,
I was looking for tumors with this eosinophilic secretory material, and when I read about this tumor, I don't know,
it
it sort
seemed
of
to
fit,
fit.
and
All
even
right.
the
So,
site and
so you did
everything.
matching pictures, which is not bad. If you don't know what something is, well, you can match pictures. But what do we see? We see an epithelial tumor in squamous mucosa. Yeah. The tumor is composed of cystic and solid areas. Cystic areas have got small excrescences. Solid areas have a follicular, if you wish, or acinar pattern, and there is a colloid-like material in the follicles. And you have three choices here: benign, malignant, or don't know. Which will you pick?
Malignant.
Malignant, okay. Anybody else? Well, if I were me, I don't find anything terribly malignant unless you go and match a picture. So I would say don't know,
Mm.
okay? And when I say don't know, then I don't know what to say, whether it is benign or it is malignant. Hmm? So how do we approach salivary gland tumors? Okay, there is a diagnostic approach and it is very simple. And if you use this in you don't even have to go and match pictures. You will know exactly what it is. All right. Now, salivary gland is organized in a branching ductal system. All right, and you can see the branching ductal system here. You see the acini. Now, do you see these acini?
Yes, ma'am.
This is the terminal portion of a secretory system which has ducts. So you have secretory acini at one end and the excretory duct, which you can't see in this because it's a large duct. You know that you have Stenson's duct and other ducts will be there. Now, acini pour their secretions into an intercalated duct. This is called a secretory duct or a striated duct. And I will show you where that striated duct is. This is the striated duct. Okay? Over here, you can see another one over here. You see another one over here. It's so pink and it has an oncocytic appearance. It is called, for some reason, it's called secretory duct. I have never understood why. And then there is an excretory duct. Can any one of you who's taking this Neelam? Neelam,
Yes,
can
ma'am.
you show me where the intercalated duct is? I've shown you where the secretory ducts are, the striated duct. Now, show me where the intercalated duct is.
Ma'am, is it this one?
That's the same. It looks the pink, same pink that you are seeing
one.
there. Mm.
This.
Where have you marked? Yeah, absolutely. Can everybody see this? It's a small duct that is within the lobule, and it's not what you marked the first time, but this is what is an intercalated duct. I think if I go next, you'll actually see where I have marked it. That is the intercalated duct, and it's very difficult to see in salivary gland, normal salivary gland preparations. Will anybody tell me which salivary gland this is likely to be? Is it a major gland or a minor gland? Come on.
Major. Parotid.
It's the parotid. Why is it the parotid?
Because of serous acini.
Because it's
Predominantly.
all serous. That's excellent. So now tell me which gland this is, and then we will just quickly describe what is going on. Is this a serous gland or is this a
Serous gland.
serous? Are you sure?
Yes,
Is this
ma'am.
a serous gland?
Predominantly,
Seromucinous gland.
it's serous. It's seromucinous. There is some mucinous compound.
So if it's a seromucinous gland, which gland is it? Of course,
Either
you
minor
can you see
or-
the mucinous? Huh?
Yes,
1 minute,
ma'am.
1 minute. Somebody said something. Is it a minor salivary gland? Did anybody think it was a minor salivary gland?
I was saying that it can be either minor or
Really,
submandibular.
Why? What are the minor salivary glands? What are they?
Seromucinous.
Seromucinous?
Yeah, but they are predominantly mucinous. So I would go for major only.
So which major?
Make submandibular.
So yeah, it is the submandibular. There is no other, sort of argument about it. You can see that this has here. This is the mucinous component. You can see there's more than one mucinous component in this in the acini. So it is the acinus that is either serous or mucinous. Okay, the ducts cannot be mucinous or serous. It is only the acini. All right, very good. So you have a two-tiered organization. You have luminal cells, and then you have abluminal cells away from the lumen. Now, it's important that you know that the abluminal cells in the acinus and in the intercalated ducts are all myoepithelial cells. Okay? So that second layer of cells are all myoepithelial. The abluminal cells in the striated duct are occasional basal cells, but mainly myoepithelial. But when you come to the excretory ducts, they are all basal cells. Please understand this. There are two layers. They look the same when you look at them under the H&E, on an H&E slide. But they look the same, but you get both myoepithelial as well as basal cells, which have no SMA in them. So the myoepithelial cells look like basal cells, but they have smooth muscle actin, because the purpose of that smooth muscle actin is to squeeze the secretion along. The moment you come to the striated duct, you have myoepithelial cells, but basal cells are now beginning to be seen, which do not have the myoepithelial component. Okay, so that's how we look at this. Now, what happens under conditions of neoplasia? The luminal cells will give rise to mucinous cells, squamous cells, sebaceous cells, acinar cells from the acini, some oncocytic looking cells, and other non-specific ductal lining cells. So, depending on where you are in the entire acinar ductal system, all of these different kinds of cells may be seen in the luminal part of the cell. But when you come to the myoepithelial cells, which you can't even see under normal circumstances, the myoepithelial cells under conditions of neoplasia will produce a variety of different forms. Sheets, clear cells, cribriform patterns, spindle cells, hyaline material is produced. You can get mitochondrite, you can get chondroid, sometimes even bone. They look plasmacytoid, and they show squamous differentiation, which is often keratinizing. Yeah, so you do get squamous differentiation in luminal cells, but they are usually non-keratinizing. Okay, you know what I call these myoepithelial cells? And the dental people know this very well because I give this talk to the dental people a lot of time. I call it the Cinderella cell. And anybody who knows the story of Cinderella, I don't know how many of you know, that Cinderella was an orphan child who had step sisters, okay? And these step sisters used to dress themselves up in finery. They were always noticed, and Cinderella was made to do all the housework and swab the floors and all. And cinder, the word cinder comes from the fact that she had to clean out the fireplaces. In the fireplace, you get cinders. And her name was Ella, and they mockingly called her Cinderella. So you never noticed Cinderella because she was always covered in dirt, and she was never taken to any kind of parties or anything else until the fairy godmother came along, and she with a wave of a wand. Cinderella was dressed in finery, and in the end she won the prince's heart. So when you think of a myoepithelial cell, which you never notice, you can't notice myoepithelial cells, but when the myoepithelial cell, under conditions of neoplasia where some wand is waved, the myoepithelial cells can transform themselves into all these huge different kinds of types, make different kinds of stromas and everything else. So we should look out for myoepithelial cells. That's very important. And I like to think of salivary gland tumors in this way. The cells, the salivary gland tumors that have myoepithelial cells and those that do not. And this is a short list because we don't see more than these kind of tumors usually. Okay? So myoepithelial cells, the epitome of a myoepithelial cell containing tumor is a pleomorphic adenoma, because you see all types of myoepithelial cell morphology as well as stroma. The adenoid cystic carcinoma is the next one. And you have the epithelial myoepithelial carcinoma, and you have myoepitheliomas and myoepithelial carcinomas. But the tumors without myoepithelial cells are Walton's tumor, which is from the excretory duct, mucoepidermoid carcinoma, actinic cell carcinoma, secretory carcinoma, hyalinizing clear cell carcinoma, and some high-grade duct carcinomas. Okay, PLGA is polymorphous low-grade adenocarcinoma. Good. So my approach is very simple. Look at the histology, notice whether a tumor is monomorphic or pleomorphic. And what do we mean by pleomorphic? Not having bizarre cells and a lot of anisonucleosis or anisocytosis. What does pleomorphic mean? It means
Different kinds of cells.
Kinds of cells. That's right. So then we look for recognizable or suspected myoepithelial components. And what is that? variety of matrices, chondroid, myxoid, hyaline, plasmacytoid or hyaline type cells, spindle cells, clear cells, adenoid structures. They are not glands. They are adenoid. What is in the center of that is actually stroma, which has got either hyalinized or full of some kind of bluish myxoid. So what's inside those in cribriform structures when you are looking at an adenoid cystic carcinoma is not true. They are not true glands. That's why we call them adenoid and keratinizing squamous elements. And I have talked about keratinization over there. Right. And then you look for lumina, you look for individual cell mucin, oncocytes, cellular atypia, circumscription, etc. Now let's come to our case. What should you ask? Is this a salivary gland neoplasm? Because sometimes things look like salivary gland neoplasms, but they're not. So ask the question first. Is this likely to be a salivary gland neoplasm? Does it contain myoepithelial cells? Then ask, is it benign or malignant? And what is the type? So let's do that with this particular thing. And Neelam, since you were the person,
Yes,
start. Is this a salivary gland neoplasm? Was the answer?
Yes, ma'am.
Yes. Why? Because it is recurrent and it shows true lumina, which may possibly be acinine. What's the next question? Does it contain myoepithelial cells? What's the answer?
No, ma'am.
Yes, that's right. It does not contain myoepithelial cells. You never saw anything that looked like a myoepithelial cell in this tumor. It's not spindly. There is multivesiculation, but there is no, clearing. These are not clear cells. There was multivesiculation over there. There were no hyaline cells. There was nothing that you would be able to look at and say, I think that is a myoepithelial cell. Next, now comes the question, is it benign or malignant? And how do you answer that question? You can either go and match pictures like you did, okay? But it's simple. This cannot be a benign malignant because there is no benign tumor. You know all the benign tumors. Yeah, pleomorphic adenoma, which should have, or a Warthin tumor, which this is not a Warthin tumor. So what are all the benign tumors you know in the salivary glands? There are very few, and this doesn't look like any one of them. So it should be a low-grade malignant tumor. And next comes what type. And now we have already said that we don't see any myoepithelial cells. So you don't even have to think of the tumors that have myoepithelial cells. And what are these? No, tumors without myoepithelial cells, you know the list. Warthins, mucoepidermoid, acinic, secretory, hyalinizing, clear cell, PLGA, and high-grade duct carcinoma. We know it's not high-grade, so high-grade duct carcinoma is out. So now when you pick the only one that it can't be a Warthin tumor.
Oncocytic cells are not there.
No. Is it mucoepidermoid? No, you didn't see any individual cell and there was no epidermoid. Acinic? Yeah, possibly. In fact, this tumor for years was called an acinic cell carcinoma until it was discovered that this is not an acinic cell carcinoma because it shares a molecular marker with the secretory carcinoma of the breast. So this tumor is a secretory carcinoma. That is the mammary analog secretory carcinoma. But for years, it was we described it or we reported it as an acinic cell tumor. Okay, and this has got a specific translocation. It is the ETV 6 NPRK translocation. Okay, so that's what this tumor actually is. Now I think we better hurry up. We've got the last case, and who's going to take that? Ashish?
Yes, ma'am. I will be taking.
Okay, very good. Come on.
69-year-old male, re-excision of site of salivary gland tumor is done in palate.
Right. So what do you mean by that? What do you understand by that history?
It is a recurring lesion.
It's a recurrent lesion? Is that what you understand by this history, Ashish? Re-excision of the site of a salivary gland tumor in the parrot. What do you understand by that history? You understood that there was a recurrence?
No, ma'am. This is the site of excision is that of the previous salivary gland tumor.
So why are they re-excising it? What do you think this surgeon is doing? Anybody else?
I think so.
Yeah, sorry, yes, carry on.
There is a suspicion of malignancy or reappearance.
So you think that it has, the surgeon thinks that there is a reoccurrence. Anybody else? Neha? Yeah, Neelam, okay.
Ma'am, it would show that there is history of surgical intervention, and whether the lesion is the same or no, that we can't say.
That's what they want to do. Okay, Kshitija?
Ma'am, it is a minor salivary gland tumor, and some tumors are malignant by their nature. Maybe in the first excision, what diagnosis was given, so that was a malignant tumor. So,
I see, okay. So you think so. What about you, Neha?
Ma'am, it could either be a recurrence or some change happening in that post-op site, or it could be something that is remaining, or some other change, or a totally new tumor also.
When there's something called re-excision at the site, re-excision means what? That something was excised before and they feel that they haven't got it out completely, right? And that's why, and particularly in the palate, if somebody wasn't expecting the diagnosis to be a salivary gland tumor and they went in and did a bit of an excision, right? And then they discovered that the margins were not positive, were positive, or they weren't sure whether something had been left behind. Then they go and re-excise that particular site. So that is what has happened in this particular case. Okay, Ashish, come on.
On this power, I can see the normal squamous mucosa over lining it. On the right upper hand, there are normal salivary glands, minor salivary glands, and there is a ill-defined lesion in the subepithelial tissue.
Okay.
Forming glands.
Anything else? Ill-defined lesion in the epithelial tissue. Okay. Glandular lesion, that's what you're calling it. Okay.
Yes,
why are you calling it glandular, Ashish?
Ma'am, I can see spaces that are lined by single, I think so, layer of cells.
Okay. That's why it's a gland. That's your definition of a gland, Ashish?
No, ma'am.
No, ma'am. So?
Some cystic...
So what do you want to call this? What do you want to call these structures? There are structures here, right? All these structures? Yeah, there are so many of them. Small, large, whatever. So what do you want to call them? You know, Ashish, you have to be very, very carefully observing everything over here. This is low power. All right. Do you see anything anywhere in the rest of this slide that looks or resembles these things? No?
Yeah, the saliva.
Do you see this? Do you see this thing or not? This is the minor salivary gland?
Yeah.
Yes? This is the minor salivary gland that you're seeing here? Yes? Beautiful lobule of minor salivary gland. What do you think this is? What are all these little rounded structures? Can you see them?
Yeah, these are the ducts.
They are ducts. Wonderful. And what are the acini over here? The glandular part of this thing?
Mucinous.
Mucinous. So now, Ashish, you want to Go back and say
Yes.
what you think these things are.
Duct-like proliferation.
It's not duck-like. They are ducks.
Duct,
And
duct.
you can see not only are they ducks, but they're branching, right? So
Yes,
there
ma'am.
are duct-like structures, ducts and ductules. You want to call them ductular, whatever, but they are branching over here.
Yeah.
It's interesting, isn't it? And then you
Yes.
see something else, my dear Ashish, that
And
here
ma'am,
and here, in the region of this abnormality, I'll tell
there
you,
are
I'll just mark it. In the
solid.
region of this abnormality, what else do you see? What do you see? Do they look like ducks to you now?
No, ma'am.
No, what are they?
Glands.
Yeah, they're acini. So
Acini.
you've got acini here, acini here. There are no glands, okay? This whole thing that we said was a lobule of a minor salivary gland. That is an anatomical gland. It's not histologically, you can't call it a gland. Do you understand what I'm
Okay,
trying
ma'am.
to say? Yeah, that thing is, this whole thing is a lobule of, I'm technologically challenged. This is a minor salivary gland, but these are acini, and in the middle of it you have acini, and you have ducts. Yes, here you are, ducts, and the rest of it of this is acini. So you're seeing that over here, Ashish. Can you see that or not?
Yes,
You
ma'am.
see ducts which are dilated, yes, branching, and at the bottom somewhere you're seeing some acini.
Acini.
Okay, very good. And this is something that you should have been able to spot at low power. Now, as you come towards the surface, what do you see?
There, there is a bit squamoid differentiation of the ducts.
Very good. You have ducts with lumina, and then you
Yeah.
have other structures that
Structures.
look like they may be ducts. Yes, but the
Yes.
lumen is filled up with squamous cells. Yeah, and you can see that
Yeah.
there's some here and there. So that is near the top.
So,
This one is near the bottom, and this is where you have got very odd-looking ducts and cells, right? Why, Ashish? Do you think that? Yeah, tell me, what is the reason for this peculiar appearance where the ducts are filled with cells that are looking spindly, drawn out?
and
Yeah, why is that?
it can be a metaplastic change of the ducts.
Metaplastic change. Okay. Anybody else would like to say? Yeah. Why are these cells looking, these ducts, the cells within these ducts looking so peculiar? Anybody?
Ma'am, I think the surrounding there is a lot of fibrosis and
Fibrosis, okay.
it's probably compressing the ducts, and that's why that flattened.
Okay.
Ma'am, in chronic sialidinitis, because of the back, there is the ducts get obliterated, and
Ducts get obliterated. But aren't they very peculiar? You saw nice lumina here. They are all, look at the cells. Don't you see that they look spindly?
Spindly.
Yeah,
And
and
some
dark.
clear cytoplasm.
No, it's not. Yeah, well, the cytoplasm may be clear, but the nuclei are very dense and very spindly. Okay. You've never seen crush artifact in your life? Right. This is an artifact in tissues, and it's either crush or it's a burn. That means it is a laser or something else has been used to cut this. So that we have to discard because we can't see anything of any use in that particular areas. So there's no need now. It's not dysplasia. It is not anything like that. This is an artifact from the previous surgery. Now here, come on, Ashish, tell me.
there is the ducts show a luminal and an abluminal differentiation
Mm-hmm.
with areas having squamoid with ducts having squamous like differentiation, and there is
Yes.
some cribriforming over it.
Yes. So there is some cribriforming which we can see. Yes. Excellent. Multiple little. But what do you want to say about cribriforming? Whenever we see cribriforming inside a duct, what should we be noticing next? Because we see it, no? We see it in the breast. We see it in
Some necrosis.
necrosis. All right. There's no necrosis over here. Well, there's something that's fallen off. Okay. What do you want to say? You want to see whether those spaces that it's a sieve-like thing, no? Cribriform
Yeah.
means that it's got holes like a sieve. Are they regular or irregular? Because if it is regular, what does it mean? What does regularity in cribriform space mean?
A malignant.
That's right. So the regularity, which normally means benign in many areas, regularity in the cribriform space means malignant. Irregularity suggests that it is benign. Now you want to tell me whether this is regular or irregular?
It's irregular, ma'am.
Irregular. So this cannot be something on this basis. You can't call something malignant. Excellent, Ashish. Very good. Now here, what about this?
The cells show similar areas with extensive squamoid differentiation, and there is the stroma of there is a myxoid stroma, I think so.
There's a myxoid stroma. That's okay. It's a young fibroblastic stroma. But are you going to tell me that all of this is squamous differentiation? Yeah, I take it that something that at the bottom right-hand corner here is squamous differentiation. Yeah. But do you think all of this is squamous differentiation, Ashish? Describe those cells, please, that you are seeing here.
Cells are
In this thing, say, just take this as an example.
They are oval to round, having a clear cytoplasm, distinct cell membrane, and a uniform
So they're
brown
cuboidal,
nucleus.
young man. They're not oval to round. The nuclei are oval to round. Please get out of this dirty habit, all of you, of looking at the nuclei and saying that that's the shape of the cell. The shape of the cell is cuboidal. You're just saying that you're seeing round cells with distinct nuclei, distinct borders. No. So
it's cuboid.
they're all cuboidal. They're clearish and they have very sort of dense looking nuclei that are in the center of the cell. Okay, but so everything is certainly not squamous. So come on now, Ashish. What do you think this is?
Ma'am, I think it is a benign lesion.
You think it's a benign lesion? Very good.
And the primary of the site of lesion, it is a salivary gland lesion with a benign.
It's a benign thing. Now, if you had described this at low power, and I've got it here for you, it's an intact overlying squamous epithelium. Yes? There is a wedge shaped, you know what is a wedge? Here is the wedge. On one side, you have a normal salivary gland, minor salivary gland lobule. You had another one on the other side. Part of it has got cut off. We've got, of course, this, artifact at the edge. But there is a wedge-shaped abnormality sandwiched between two well-preserved mucous salivary glands. Yes? The lesion actually appears to radiate towards a dimple in the overlying epithelium. Can you see that?
Yes, ma'am.
Beautiful dimple over there. And the abnormal area reaches the base of the excision. Now that is how I want you guys to get your thoughts together in this way. And not, wonder, you're there everywhere. There has to be some kind of congealing of your thought process. So it comes out in one or two sentences as exactly what you are seeing. Okay? You just can't wander here and there. All right, now this is high power. So what are you going to see at high power now? Ductal
The ductal.
structures lined by immature squamous cells. See, these are not keratinizing squamous cells. And this is what you see in immature metaplasia in the cervix. And somebody asked at, I think, at some stage or the other, I don't know whether they asked me or they asked Asavari, what is an intermediate cell in a mucoepidermoid tumor? Look at these cells, and these are intermediate cells. Okay, they are like immature squamous cells. And then, of course, you have these cribriform areas and solid islands composed of this sort as well as keratinizing cells. Yes or no? Focal keratinization is noted. Excellent. Now, what is not noted over here? We've noted everything that we have seen, but what is not noted? There is no mucus. Individual mucin secretion is not there. So we are seeing intermediate cells. We are seeing some amount of keratinization. And I said at that time, when we were talking about mucoepidermoid tumors, that mucoepidermoid tumors do not keratinize. Okay, so there's no mucin, there is keratinization, and yet you have intermediate cells. Okay, so what is this peculiar thing? Now we have to, stromal desmoplasia, as you said, it's young fibrous tissue, is present. So we know that this is re-excision of the site of a previous salivary gland tumor of the palate. So what is it that is this clinician asking us about this tumor, about this, this re-excision? What do you think he's asking? What do you think he's asking? Tell me the diagnosis. Is that what he's saying? They ask us many questions, you know.
Residual tumor.
What is the clinical question in this case?
Is something remaining?
Is it or is it not residual tumor? Now, Ashish, is it or is it not residual tumor? We don't know what that tumor was.
Hello.
Yes, Ashish, I can hear you. Can you hear me?
Ma'am, yes, ma'am, I can hear you. What was the question? Can you please repeat?
There it is, no? On the top, can you see? What is the clinical question in this case? Is it or is it not residual tumor? That's the question. So,
it's not a residual tumor.
It is not residual tumor. Come on, Neha. Is it residual tumor or not residual tumor?
It is not, ma'am.
Not. Neelam?
No, ma'am, I don't think it's it.
It is not. Okay. What about you? Kshitija? She doesn't know. She's being honest. She doesn't know. How are you going to know whether it is or it is not? How would we know for sure? Yes, Ashish?
No.
You find out what was the subtype of the original tumor. Okay? Now they say that they have lost the... So it may not have been a salivary gland tumor at all. Perhaps it was a squamous carcinoma. Then? So try and get the original tumor.
Okay.
Here is the original tumor. And you know, people say, nahi mil raha hai. But if you make enough efforts, there you are. It has come. This is the original tumor. Now, Ashish, what do you want to say about this original tumor?
On this power, ma'am, there is reforming of the ducts that are seen.
Reforming of ducts. Okay, let's see it at a little higher power. You've got an intact palatal epithelium on top. Yes?
Yes, ma'am.
Squamous epithelium. And then in the subepithelial tissue, you have this tumor. Yes. And what is it composed of?
Yes.
And if you say glands, Ashish, I will shoot you. What is it composed of?
That's
what?
a
What
bit
are
of
all these structures that you are seeing here? They have to be ducts. No, they're not glands.
ducts, ma'am. Yes, ma'am.
They're ducts. So there are lots of ducts in varying sizes, and then you have papillary structures as well. Look at this.
Yes, ma'am.
So there's a papillary structure, and then you're seeing these things below. What is this called?
Cribriform.
Cribriforming
So
gland.
there are cribriform structures, there are tubules, there are ducts, some lined by 2 layers of epithelium, some just single layer of epithelium. There's some inspissated material inside these ducts. And this is another area which is showing ducts again. See, elongated,
Yes.
lots of ducts. So now Ashish and Neelam and Neha, do you want to say what this neoplasm is? No, is this a salivary gland neoplasm?
Yes, ma'am.
Yes.
Yes, ma'am.
Yes. Oh, sorry, yes. Does it contain myoepithelial cells?
Yes.
Yes.
Yes. Really? Where did you see the myoepithelial?
No, I didn't see.
Not sure.
So Ashish didn't see. So he's right. There were no myoepithelial cells. Now the question is it benign or malignant?
Malignant.
Malignant.
Why? Why?
The cribriforming is regular.
Because of the
Yes.
cribriforming being regular. There were no myoepithelial cells.
Epithelial
And no
cells.
myopathy.
There are no myoepithelial cells. So which is the only benign tumor that you should know? Remember, which has no myoepithelial cells? Here I put it up for you. Which is the only benign tumor that does not show you myoepithelial cells? For God's sake, it's a Warthin's tumor. So you think this is a Warthin's tumor? No, you said that there were no myoepithelial cells, so you have to pick one of these. So which one will you pick? Come on,
So,
Ashish.
ma'am, in the poll, 53% is picking mucoepidermoid, and
Okay.
27% is going with PLGA.
Oh, okay. So now you pick, Ashish. Mucoepidermoid, acinic, because all of these, it can't be Warthin's. It's not,
Yes,
okay?
ma'am.
So mucoepidermoid, acinic, secretory, hyalinizing clear cell, PLGA.
Ma'am, I think it is PLGA.
Of course, mucoepidermoid tumors don't produce papillary structures, and we never found a single.
Mucinous line.
In this case, it may not be there because we are talking about this particular, the previous, the excised salivary gland tumor. A mucoepidermoid tumor will never produce papillary structures. Will not show you these, which we'll go previous and show you. Look at this. Will this ever be seen in a mucoepidermoid tumor? It's highly unlikely, right? There are oncocytic variants of mucoepidermoid tumor, but then they are nearly all oncocytic. You can't suddenly find this kind of appearance. So, now tell me, what is the type? Everybody agrees? It is? Malignant. The type is PL.
Polymorphic.
Yes. It's a tumor full of ducts. It's making ducts. And it is, now we know that this is PLGA. Excellent. So now, Ashish, answer the question. Is our position, is it or is it not residual tumor?
Ma'am, I still feel it is not a residual tumor.
Okay, very good. What, has anybody else changed their mind? You saw the previous one.
Yes, ma'am.
Neha?
No, ma'am, I still think it's not.
Yeah, even I think it's not.
And now what about our doubter?
Yeah. In
Okay,
the
yes.
poll,
In the poll.
75% are going with yes.
Sorry, how many people think?
In the poll, 75% feels it is a residual tumor.
It is residual tumor. Arey wah. See? And what about you, Kshitija? You still don't know?
No.
No, ma'am. In the end, the thing has come to you, you have to make up your mind. Okay, sorry. So we know that was a PLGA, that's the subtype. So what does this present biopsy show? We have to say, is it or is it not PLGA? Why is it important? Because if it is, then the excision is incomplete. You saw, no, we had a margin that was positive, and then the surgeon will have to go back and do some laserization or something else, or do a larger re-excision. So if no, then what is it? And you're all saying no. So then what is it? 75% of these people think yes, 25% say no. And here I've got 75% who think it is not. So they'll have to tell me.
Ma'am, can it be some post-operative changes?
Post-operative changes.
Like a cyalometaplasia.
Yes. So what did you think, Ashish?
Ma'am, I thought it is a cyalometaplasia.
Ah, very good. See, if you go back and if people think at what they saw at low power and high power, first of all, it was a wedge-shaped abnormality sandwiched between two well-preserved mucous salivary glands. All right, this was an entirely ductular structure. There were no except in one area where you actually saw that there was some acini, mucus acini, right? In one part of the thing, and the ducts seem to be actually ensuing from that particular area, and they were all pointing towards that dimple. I don't see why a tumor will go in this radiate fashion and come to a dimple, which suggests what? That this is a duct, and this is a ductal structure that is part of what was originally a mucus gland over there, which has now been stitched together in the previous excision. Okay, and you will now see that the diagnosis is cyalometaplasia of minor salivary gland, and there is no residual tumor present. So the three of you made a very good diagnosis. I hope it was not a guess, because even if it was a guess, it's an educated guess. Kshitija, which is a good kind of educated guess. Kshitija, you have to wrap your head around this and now think, why is it that you did not, focus down on making this diagnosis? All right. I think this is the last case and we don't have any more. Gaurav, if there are any questions that people are asking, or if the four of you want to ask any questions, I'm happy to answer them. But I must say that I appreciated the efforts that you guys made. You got your answers right in the majority of the instances. I hope you know now why you were right. Okay, because there is a famous saying, you can be right for the wrong reasons. So you all have to be right always for the right reasons. And I must appreciate the fact that you did this. Any questions, Gaurav?
Ma'am, we have one question. Somebody is asking that what is the difference between pleomorphic and polymorphous?
Well, pleomorphic normally means the way that we use pleomorphic in the way that, not for salivary glands but in general. So pleomorphic means variation, marked variation in size, shape in the cells or in the nuclei, so that they look really very, very, very anaplastic. That is what is pleomorphism. The same cell or the same types of cells are showing you marked variation in nuclear size and shape. So, say you have a carcinoma. We know that carcinoma is, say, arising from a gland, and it is an adenocarcinoma. You call it a pleomorphic adenocarcinoma if the cells are all showing you marked variation in size and shape. Okay, so that's pleomorphism. Polymorphism is like what you have in Hodgkin's disease. All right, you have many different kinds of cells that are forming the lesion. So you have Hodgkin cells, you have lymphocytes, you have polymorphs, you have plasma cells, etc. So that is polymorphism. There is one exception to this rule, and that is what we talked about today. We call something a pleomorphic adenoma, where this this tumor is composed of one type of cell. The stem cell is the same, but that stem cell under normal conditions gives rise to both the luminal and the abluminal cells. The luminal cells produce all the variants of luminal cells. The abluminal cells produce all the variants of myoepithelial cells that you can see under conditions of neoplasia. So you have various types of cells, but all arising from one stem cell. So pleomorphic adenoma is not a cell, is not a tumor that arises from cartilage and bone and glandular differentiation, etc. It's one stem cell that has the capacity to produce both luminal and abluminal type structures of varying types, and that's why it was called a pleomorphic adenoma. But most people don't use that term, pleomorphic adenoma. The surgeons, etc., call it a mixed tumor because of these various different kinds of structures as well as tissues that seem to be produced by this one tumor. So that is what is the difference. If there is any other question, or if they haven't understood, I'm willing to repeat the whole thing again. Anything else, Gaurav?
No, ma'am, no more question.
All right. I thank you for your patience. I thank you for
excellent session. I think with the even at this point, I think we have more than 1,000 participants still here. I think it was a really helpful discussion.
Gaurav, I don't think that we should judge how good or bad a session was by the number of participants. But if they were interested and they wanted to stay on, I am glad. I just hope that they learned something. And if there are any questions, I'm very happy to take them. You can give people my email address and I will answer them. There was I did this session for the Belgaum conference, and what is the question that people wanted to be answered, and I got a flood of emails, and so I'm going to write a little thing and send it to them. They wanted to know about nuclear features. Everybody talks about cytoplasmic features, but we want to know about nuclear features like chromatin and all these sort of things. So if anybody else wants to know, I can send it to Gaurav as I make a little thing on chromatin, and then you can send it along to all the people on Telegram. So then I don't have to answer each person's email. Yeah. Thank you so much, all of you. I hope
Thank you, ma'am.
Thank you so much.
Thank you so much, ma'am.
So we have just a little bit announcement. So with the positive feedback that you have got of the slide seminars, we have decided to conduct more slide seminars. This will be conducted in the first and third Monday of every month at 7 p.m. where like this 4 final year MD pathology residents will be chosen who will go over the microscope, quote unquote, like a similar experience with an expert histopathologist. And the slide images and history will be uploaded in the Telegram group well in advance, at least 1 week in advance. So we request HODs and teachers to recommend students. Students can also volunteer. So this is the email where you can send a mail, onlineteachpathology@gmail.com. Send a mail with this subject as interested to take part in PG slide seminar. And please mention this information like name and designation, email ID and phone number, and the name of the institute that you belong to. And just one more thing I want to show, which is that our next, just give me 1 minute. Yes, so this is our next slide seminar, which will be on Monday, August 17 at 7 p.m. The theme of this is peripheral blood smear red cell morphology, and the presenter will be Dr. Veena Das and team from PGI-MER Chandigarh. And finally, we have come to the end of today's session. I think I just have to just one more slide I have. I think.
Gaurav, I have to thank you. You have been very patient. You have been conducting the polls. You have been, uploading the slide, the presentation. All of you have to be very, very thankful to Gaurav.
We are also
Yes,
thankful to
thank
the
you.
4 residents because
For
they.
me, it's okay. I'm technologically challenged, and he's very patient. All of you are very patient. Thank you.
And lastly, this is our upcoming talk on next Tuesday on 11th August. So this will be on the testing for COVID-19, which will be taken by Dr. Tanu Singhal, who is a consultant at pediatrics and infectious disease in Kokilaben Dhirubhai Ambani Hospital, Mumbai. And the session will be chaired by Dr. Nikhil Patkar, who is a clinical scientist and associate professor here at Extract Tata Memorial Center, Mumbai. So I hope to see you all on 11th August for this discussion. That brings to us to the end of this session. We really thank ma'am and all 4 of you because you have volunteered for our first slide seminar. We really hope to have a lot of more of these for everyone. Thank you.
Sure. Yeah.
All right.
Thank you.
Okay.
Thank
Take
you, ma'am.
care. Enjoy your Sunday. How many